الدكتور رافد عزيز رئيس الجمعية الطبية العراقية الموحدة في الأمم المتحدة وأيضا.
شكرا جزيلا دكتور مؤيد. شكرا جزيلا اخوان الاعزاء، اخوان الاساتذه افاضل، شكرا على حضوركم ومشاركتكم المؤتمر السنوي هذا المشترك بين الجمعيه الطبيه العراقيه الموحده وبين جمعيه تخدير وعلاج الالم العراقيه. احنا نتشرف بحضوركم اليوم. الحقيقه السنه الماضيه كانت سنه صعبه جدا على الجميع، وأحب أولاً يعني أنه نستذكر اللي صار خلال هذه السنة الماضية، وأيضاً نتكلم على برامجنا التي نتوقع أنه إن شاء الله نحققها بمشيئة الله للسنة القادمة. فأولاً أرحب بكم في المؤتمر الأول لهذا العام الذي تنظمه الجمعية الطبية العراقية الموحدة في المملكة المتحدة وأيرلندا وبالتعاون مع الجمعية العراقية للتخدير والعناية المركزة. لقد آلينا على أنفسنا أن تكون باكورة فعاليات جمعيتنا لهذا العام في اختصاص التخدير، لما كان لهذا الاختصاص وأطبائه المجاهدين من دور كبير ومشهود في صد الوباء. لقد كانت هذه النخبة المشرقة من أطبائنا في خطوط الصد الأول في العناية المركزة ومستشفيات العزل وردهات التنفس الصناعي، وكانوا ولا زالوا يقدمون خدماتهم الجليلة بصبر وجلد وعنفوان، لم يهزه نقص في الأدوات والأدوية أو ارتباك في التخطيط والاستراتيجيات. وفي خضم هذه الحرب الشرسة فقدنا زملاء وأحبة كانوا في مواجهة هذا الوباء الشرس، وأذكر منهم أطباء التخدير والعناية المركزة الدكتور خالد فاضل علي، الدكتور محمد حارث الزويدي، والدكتور حيدر حسين الماس، وغيرهم الكثير من الأطباء والممرضين والتقنيين الذين ضحوا بحياتهم من أجل إنقاذ أهلنا ومواطنينا في العراق. دعواتنا إلى الباري عز وجل أن يتغمدهم برحمته الواسعة، وأن يتقبلهم مع الشهداء والصديقين، وينزلهم منزلا حسنا ويسكنهم الجنة إنه سميع مجيب. إن الجمعية الطبية العراقية الموحدة في المملكة المتحدة وأيرلندا ومنذ تأسيسها كانت وما زالت السند والداعم للأطباء وكوادر الصحة في العراق، وشاركتهم آلامهم ومعاناتهم، كما شاركتهم تطلعاتهم وأمالهم، وكانت الصوت الذي ينطق بالحق وبدون محاباة أو مجاملات. إن الجمعية هي الامتداد الطبيعي لمجتمعنا الطبي في الوطن الحبيب، ونستشعر ما يمر به من صعوبات وتحديات، ولذلك فإننا لم نتوقف حين توقف الكثيرون، ولم نهمل أو نكسل حين مال البعض إلى السكينة والراحة، ولم نبخل بجهد أو وقت للتواصل وتبادل الخبرات والمعلومات. وكانت السنة الماضية خير دليل على ذلك، إذ عقدت الجمعية ونظمت العديد من الاجتماعات والويبينارات في مواجهة الوباء وفي إدامة التعليم الطبي والتطوير الطبي في نفس الوقت. نذكر من ذلك مؤتمرات متخصصة في الاختصاصات المختلفة من النسائية والتوليد والجراحة والأمراض النفسية والعناية المركزة وطب الألم. ولم يكن الأطباء الشباب والخريجين الجدد ببعيدين عن منظورنا المستقبلي، فلذلك قد عقدنا دورات تدريبية للإنعاش في بغداد، ومن ثم سلسلة محاضرات متخصصة للأطباء الجدد وطلاب كليات الطب في طب الطوارئ والجراحة. إن تواصلنا مع نقابة الأطباء ورئيسها السابق الدكتور عبد الأمير محسن كان فعالاً ومثمراً، وقد أخذت الجمعية على عاتقها أن تكون الجسر الذي يوصل الأطباء في المهجر مع نقابتهم في البلد الأم، وكذلك كانت الصوت الذي يعبر عن إرادة الأطباء حينما يتعرضون للضغوط والمضايقات. وفي بعض الأحيان كانت الجمعية الصوت البديل لنقابة الأطباء حينما تعرضت النقابة للضغوط. فقد كان لنا صوتا متميزا في بناء الاستراتيجية الناجعة لمكافحة الوباء، وكذلك الضغط لتصحيح بعض التخبط الذي رافق مكافحة الوباء في بدايته. وأملنا كبير أن نكمل هذا المشوار والمسيرة مع النقيب المنتخب الدكتور جاسم العزاوي، والذي نتوسم به المهنية والحرص والمثابرة. لقد كان لنا أيضا تعاونا مشتركا مع جمعية الهلال الأحمر العراقية
مشاركين
بالتنسيق مع الأستاذ الدكتور هلال الصفار رئيس اللجنة العلمية لجمعية الهلال الأحمر، ونظمنا كورسات الإنعاش بالإضافة إلى العديد من الويبينارات المتخصصة في الكوفيد وعلاجه. إننا ننظر للمستقبل بعيون التفاؤل والأمل. وضعنا خططا وبرامج لتنفيذ منهاجنا العلمي والمهني، وستتضمن خططنا المستقبلية ما يلي: أولا، مشروع فينيكس العالمي بالتعاون مع جامعة كادف في المملكة المتحدة، حيث قامت الجمعية بالتعاون مع مشروع فينيكس العالمي بإنشاء مشروع فينيكس العراق، والذي سيرى النور خلال الأيام القليلة من الأسبوع القادم إن شاء الله. ثانياً، مشروع شهيد الطب ونصب شهيد الطب في بغداد. ثالثاً، مؤتمر الكفاءات الطبية العراقية في تركيا في شهر مايس من هذه السنة. مؤتمر الطب النفسي شباط 2021. مؤتمر أو مسابقة المتدربين وطلبة البود شباط 2021. الاستمرار في محاضرات تعليم الخريجين الجدد وطلاب كليات الطب. المؤتمر السنوي للجمعية الطبية العراقية الموحدة في شهر نوفمبر تشرين الثاني. الاستمرار في كورسات الإنعاش في بغداد إن شاء الله. وهناك العديد من الأفكار والمشاريع قيد الدراسة، وإن شاء الله نطلعكم عليها في حينها. أتمنى لكم النجاح والسؤدد، ولأطباء التخدير والعناية المركزة كل الموفقية والتقدم والازدهار. ولا بد لي من تقديم الشكر للجمعية العراقية للتخدير ممثلة برئيسها الأستاذ الدكتور محسن ركابي على المشاركة الفاعلة، وكذلك للمجلس العراقي للتخدير ممثلة بالأستاذ الدكتور اياد عباس سلمان، وكافة المحاضرين من العراق وبريطانيا. والسلام عليكم ورحمة الله وبركاته.
شكرا جزيلا أستاذ دكتور رافد عزيز على هذه الكلمة الشاملة، ومشكورة جدا جهود الجمعية الطبية العراقية الموحدة في المملكة المتحدة وأيرلندا. طلب صغير من الأخوة جميعا أن يضعوا الميكروفون على ميوت ما يشوش على المتكلم أو المتحدث، فرجاء الجميع يخلوها ميوت. في البرنامج الآن الكلمة للجمعية العراقية للتخدير والعناية المركزة يقدمها الأستاذ الدكتور محسن الركابي. طبعا الأستاذ الدكتور محسن الركابي أستاذنا جميعا ومن رواد الطب التخدير في العراق. أهلا وسهلا أستاذنا الفاضل.
السلام عليكم ورحمة الله وبركاته. شكرا للجمعية العراقية الموحدة في المملكة المتحدة وإيرلندا على هذه الجهود الكبيرة التي تفضل الأستاذ رافد عزيز بتقديمها في مقدمته. ونحن نشعر في العراق عظيم الجهد الذي بذل من قبل الجمعية وأعضائها لتقديم المساعدة وتقديم إخواني الأعزاء، يسعدنا المشاركة في هذه الندوة أو المؤتمر الذي يعقد بمشاركة الجمعية الطبية الموحدة العراقية في المملكة المتحدة وإيرلندا، ونشد على أيديهم ونهنئهم بهذه المبادرة الكبيرة التي أدرجت الأطباء الشباب ضمن جدول المحاضرات. لقد سعينا في الجمعية. هل تسمعني دكتور مؤيد؟
نعم دكتور.
نعم دكتور سمعك.
لقد سعينا لإشراكهم في مؤتمرنا الذي كان مفروضا عقده في العام الماضي، وللأسف بسبب الظروف التي مر بها البلد تأجل المؤتمر ولم يعقد. وإن شاء الله سنحاول عقده بمشاركتكم هذه السنة، ونحن نسعى الآن مع إحدى الشركات لعمله أو لإجرائه في إحدى الدول خارج العراق، ليتضمن أيضا إضافة إلى البرنامج العلمي برنامج سياحي لمدة 3 أيام. فقد أرهق أطباؤنا من هذا العمل، يحتاج لهم شوية راحة الحقيقة، وجاي نفكر أنه شلون نقدر نخفف عنهم. احنا الحقيقة ما نقدر نتخذ قرارات الآن في جمعيتنا، لأنه هذه نهاية الدورة الانتخابية، وقد دعونا زملائنا للترشح للهيئة الإدارية الجديدة حتى نكمل الانتخابات، اجتماع الهيئة العامة والانتخابات في الأسبوع الأول من شهر آذار، وبذلك تكون القرارات رسمية وصادقة وحقيقية ومعترف بها من قبل الجهات المسؤولة. أرجوكم الإسراع بتقديم طلباتكم زملائي الأعزاء لغرض البدء في إعلان أسماء المرشحين والتهيئة للانتخابات. هنالك الكثير مما يجب أن نتحدث به، ولكننا ننشره باستمرار على مواقع الجمعية، على الواتساب وعلى الفايبر، وأرجو أن تتطلعوا إلى هذه المنشورات التي ننشرها، ونتعاون سوية لأجل دعم الجمعية وإسناد كيانها الحالي. مرة أخرى أشكركم على المشاركة والمساهمة في هذا المؤتمر، وأتمنى من الجمعية الطبية العراقية الموحدة في المملكة المتحدة وإيرلندا دوام التعاون والاستمرار، وهم لا يبخلون بنا بهذا علينا، وأنا واثق أننا سنستمر في هذا التعاون. وأشكركم وأشكرهم مرة أخرى، ودمتم، وأتمنى لكم التوفيق. دكتور معشر ركابي.
تحياتنا وشكرنا الجزيل أستاذنا الفاضل وعزيزنا الدكتور محسن الركابي، وشكرا على تواصلك، وشكرا على جهودك الكريمة، وشكرا على منشوراتك اللي دائما نتابعها، وإن شاء الله نتواصل على هذا المنهاج ونتعاون في الإنجاز وتقديم الأفضل للعراق والأطباء العراقيين. ممنون منك أستاذ الفاضل.
شكرا حبيبي دكتور مؤيد، شكرا حبيبي، تسلم.
طبعا نبدأ برنامجنا العلمي، وأدعو الأستاذ الدكتور إياد عباس سلمان لتقديم المتحدث الأول، وأرجو من المشاركين أن يدلوا أو يكتبوا أسئلتهم على الشات إلى أن تتوفر Q&A facility. بس هسه مبدئيا خلينا نكتب الأسئلة على الشات. أستاذ إياد عباس سلمان، معك الميكروفون.
بسم الله الرحمن الرحيم. It is my pleasure to chair the first session in this beautiful conference with the Dr. my brother Muayyad Aziz. The start of this session by consultant anesthetist Dr. Ala Hussein Al-Ta'i. Dr. Ala Hussein Al-Ta'i is the first consultant in all Iraq, Iraqi anesthetist, and he will talk about very important subject. He will talk about the glucose homeostasis in non-diabetic recipient of renal transplant. And we expect a most beautiful idea will be delivered by Dr. Ala, as he worked in the Iraqi Center of Transplant in last 10 years. Dr. Ala, the mic is yours for 25 minutes, and after that, there will be a discussion and answering of the questions.
Thank you, Mr. Chairman. Assalamu alaikum. بالبدء أتمنى السلامة والصحة لجميع الأخوان بمعركتهم اللي يخوضوها ضد كورونا، وإن شاء الله نتشاف كليتنا بخير وسلامة. The subject will be the blood glucose level intraoperatively and effect on recovery in non-diabetic recipient renal transplant center. The studies is done by me and my colleague, Dr. Rafid Sudani, and my other colleague, Dr. Bushra At-Tamimi. Dr. Ayad, the paper is clear?
Yes, but just maximize the slide.
Okay.
That is right.
Sorry. Renal transplant surgery is a major surgery with a high risk for complications. And steroid therapy is a main component of immune suppression. Steroid cause attenuation of stress response, but an increase in glucose level. Sorry for that. The mouse is highly sensitive. So in our work, we depend on the steroid in renal transplant. And we use mainly the methylprednisolone. And another issue, that is the stress response. In every major surgery is the main cause of an increase in glucose production. And another thing is the insulin resistance will be found. So for these two factors, stress and steroid use in transplant, both of them will lead to an increase in blood glucose. Renal transplant is a major surgery with high risk of complications. In non-diabetic recipients, is not checked routinely. At the end of anesthesia, the recovery is affected by many factors, like blood glucose level is one of them. So the hyperglycemia and hypoglycemia is non-cause of delayed recovery. And it depends on our studies, our recovery associated with Aldrich score system. Scoring is 10. Any patient should be with at least 9 on 10 to be discharged. So what about the patient and method? 52 patients in non-diabetic renal failure patient for kidney transplant. General anesthesia was given and 500 milligram infusion of methylprednisolone in a half hour. And the glucose checked at pre-induction, then every half hour. Insulin was given 1 unit for each 10 milligram glucose increment above 200 milligram. Recovery was assessed and patient discharged when get 9 of 10 of Aldrich score. What about the delayed recovery? Delayed recovery is considered if the patient cannot regain consciousness and motor activity and hemodynamic stability within a few minutes from stopping of anesthesia. In our statistical analysis, we use SPSS version 22 t-test for normally distributed data, binary logistic region for risk assessment, p-value less than 0.005 considered significant. Result: all patients were between 18 and 50. Normal, all of them is normal BMI. The surgery time was between 180 to 200 minutes. 34 of our patients had pre-induction glucose above 100 milligram and below 200. One of them was 276 milligram, while 18 from 52 had reading between 200 milligram and 250 milligram. From them, this patient, 11 patients reached 300 milligram. Among these 11 patients, 6 patients had reading between 3 to 400 milligram. And one of these 3 patients reached above 400 milligram. There was variable response to insulin. 9 of patients continued to have incremental blood glucose in spite of insulin therapy. From this result, we can see that there is a high effect of the stress response and insulin use in non-diabetic patients. And this reading represents the change in blood glucose level. And 9 of these patients continue to have incremental blood glucose in spite of insulin. One of these patients, we reach about 100 unit of insulin, soluble insulin, to control the blood glucose. And again, in our results, recovery was delayed in 5 patients from these 52 patients. 2 patients prolonged for 1.5 hours, where blood sugar more than 300, at least 2 reading at 6 and 7 reading. We said that every half hour we do a reading for glucose level, but reading less than 400 milligram. 3 patients prolonged for 3 hours and had reading 400 and above. These 3 patients, we need to control the blood sugar by infusion of the insulin for 3 to 4 hours. Basically, there was no significant difference between the mean of pre-induction reading of a glucose and delayed reaction. That's mean in our statistic 141 plus minus 16 milligram for sugar, and those with good recovery, they have blood sugar between 1 to 122 plus minus 11, with p-value equal 0.1 for 142. So it is not significant. In this slide, we can see there was no significant difference between the mean of a pre-induction glucose level of delayed and normal recovery. That's in table 1. While in table 2, patients with high glucose reading had more odds for developing delayed recovery. That means the patient with, in this slide, we can see with high glucose level during surgery is effect on the recovery from the anesthesia. In third slide, in our results, assessment of attainment of glucose from pre-induction, which was a valid test for those delayed recovery. Again, in this slide, we can see that for those patients which have 18 patients which have an increase in the blood glucose levels, it will affect on the recovery, and 5 of them need to have a 3 hour to control the sugar. So for discussion, many studies studied that there is an increment in the blood glucose intraoperatively, like the studies of Van Zandt. He worked on 295 non-diabetic patients. 53 of the patients have sugar above 100 to 26, and 6 of these 6% above 180 milligram per deciliter. And for another study, Razol, in 2011, 6 of 59 patients have above 180 milligram. Rodrigo again has said high blood glucose associated with increased morbidity. Marshall showed high glucose associated with the graft rejection in diabetic and non-diabetic patients. Many studies like Power, Sapphire, Charity, and Thomas said that high blood glucose preoperatively is associated with more complications and hyperglycemia lead to delayed recovery. From these studies and with our studies, we can see that the increase in blood sugar in non-diabetic patients affect the recovery, and there is effect on the morbidity of our patient. Hyperglycemia in our study is managed by soluble insulin to control the acute hyperglycemia. And there is many regimes had been established for management of hyperglycemia. At 2001, Vanden presented a tight glucose strategy to control the glucose between 80 and 110. But later, Wilner and Dali, they found it did not improve morbidity and mortality, but increased attack of hypoglycemia. So now the glucose level to start insulin was different among the groups. But Elizabeth started at 200 milligrams, and the Joint British Diabetes Society and the Endocrine Society considered that 180 to 200 milligrams as our target to control the sugar. And again, the American College of Physicians, they said that we must control the sugar between 140 to 200 milligrams. So at these studies, with our work, we try to control our sugar between 140 to 200 milligrams. So for conclusion of the study, the blood glucose increase in surgery in diabetic and non-diabetic patients with unpredicted response to insulin is common and lead to complication and delayed recovery of one of them. Honestly, we see that the change in the glucose level in renal transplant patients, non-diabetic renal transplant patients, and sugar level, and it is effect on the recovery from anesthesia. And you know that the renal transplant is a super major surgery, so we must do our what we can do to control the diabetic level in our patient. And for recommendation, check blood glucose for all patients, diabetic and non-diabetic intra post-operative time renal transplant. Second, further studies with large sample in cooperation with physicians are required to see the outcome. So now in our protocol in renal transplant, that we control the blood sugar for the diabetic and non-diabetic patients before the surgery and during the surgery. And now it is routine to give insulin when the blood sugar is increased above 200 in non-diabetic renal transplant patient. Thank you very much. هاي صورة لنهر دجلة أخذت لكم إياها قبل فترة. Again, thank you very much, Mr. Chairman. I'm ready for any question.
Thank you very much, Dr. Ala. Nice thesis and beautiful conclusion. And now towards the question and answers that can be managed only by the host, Dr. Muayyad Aziz.
شكرا دكتور عياد على هذه المقدمة. دكتور علاء شكرا جزيلا على هذا التقديم الرائع. وبالحقيقة ما انتظر يعني الأسئلة بس ما جتني هسه أي سؤال. بس أنا اللي يتبادر إلى ذهني سؤالي إنه هل تبدأون sliding scale on those patients perioperatively, or do you leave it until post-operatively to blood sugar?
Now on a sliding scale, but before hours, we decided to do it for a sliding scale, but before there is not.
Okay. There's a question, another question from Dr. Muhammad Aziz. His questions are these blood sugar changes limited to renal transplants only, or other patients suffer from the same change and variability in blood sugar?
Thank you very much, Dr. Mayed. A very good question. The stress response, it is considered as a mechanism to defend against the trauma when happening the surgery. And we see that all the patients under major surgery, the blood sugar is increased. So I think it is important if there is any major surgery to do checking for blood sugar during the surgery, at least, to control the sugar and to decrease the delayed recovery or the morbidity of the patient.
Okay. Dr. Ala, have you noticed any increase in infection rates in those patients who are uncontrolled blood sugar?
Thank you very much, Dr. Mayed. Really a very good question, because all of us know that the patient for renal transplant, they're taking a lot of drug, 2 or 3 drug immunosuppression drug to decrease the immunosuppression. So to control the sugar is very important. And there is a lot of discussion between us and the nephrologist about the level of blood sugar. It is 150 or above or below to control the infection if it has happened. Honestly, we didn't see any patient with an increased percentage of infection if we control the sugar during the surgery and after the post-operative day of the surgery.
There's another question, which is basically saying, any other factors considered during your study, like acid-base status?
Yes, we take it in the consideration, but our work focusing on the 2 mechanisms which affect on the glucose level, the stress response and the steroid therapy in the renal transplant. But we take the acid-base balance in consideration when we need it.
Okay. There's a last question, probably. Do you apply the regime you mentioned to control blood sugar in other long procedures or operations?
Yes. We use to give 1 unit of insulin, each 10 milligram of sugar increase more than 140 to put it in the same range between 140 to 160. And we see that is a very good. If we use the soluble insulin 1 milligram for every 10 milligram increase in sugar.
I probably will extend the question for one more question, which is from Dr. Khalil. Dr. Khalil asking, what type of fluids these patients receive?
According to the condition of the patient, but mainly we use normal saline with colloid. So we use colloid and the crystalloid according to the need of the patient, and we depend on the central venous line. Mainly you can give between 750 to 1,000 ml of fluid. And again, it is depend on the condition of the patient.
Excellent. Dr. Ala, thank you very much for this presentation. And
thank you very much, Mr. Moyed.
And I'm back to Dr. Ayad Abbas Salman to present our next speaker.
Thank you.
Okay, thank you, Dr. Moyed. Now we're gonna turning our ears towards beautiful north of Iraq, towards the beautiful Erbil, to hear from the consultant anesthetist, Dr. Abdelhamid Al-Dabbagh. Abdelhamid Al-Dabbagh is the head of the training center for Iraqi and Arabic board students in Erbil. He will talk about very interested topics, deliberate cardiac arrest in non-cardiac surgery. Dr. Abdelhamid, the mic is yours for 25 minutes.
على يمكن إذا أنت stop sharing. Yeah, excellent.
Dr. Abdelhamid.
Dr. Abdul Hamid, you are muted.
Dr. Abdul Hamid.
Okay, I just unmuted. Sorry. Bismillah ar-Rahman ar-Rahim. Good evening. I would like to thank the United Iraqi Medical Association of United Kingdom and Ireland and the Iraqi Society of Anesthesia, Intensive Care and Pain Management for organizing this online conference. My special thanks to Dr. Rafid Aziz, Dr. Muayyad Aziz, Dr. Ayad Abbas, Ustadna Dr. Mohsen Rakabi for giving me this chance to present my subject. Actually, my subject is a case presentation with highlighting some of the theoretical backgrounds of the subject. So I chose the deliberate cardiac arrest in non-cardiac surgery. As you know that in cardiac surgery, what we do is we arrest the heart and put the patient on a heart-lung machine so that the cardiac surgeon can do either, for example, coronary bypass surgery or open heart surgery. But there are other indications for arresting the heart Yes, so we have many other types of surgery in which we need to arrest the heart, and this arresting, it may be accompanied with let's say hypothermia or circulatory arrest as well. So we have aortic arch surgery, most commonly used for elective complex aortic arch surgery, where it is impossible to perfuse the brain through cerebral vessels using a standard cardiopulmonary bypass cannulation. Type A aortic dissections, which are emergency operations, pulmonary artery thrombo and arterectomy, repair of thoracoabdominal aneurysms, tumors of invading the inferior vena cava, for example, renal tumors, complex cerebral malformation, cerebrovascular malformation, surgery of head and neck vessels, and aneurysmal brain surgery. These types of surgery, we may need to arrest the heart, and as I said, it may be accompanied with reduction of the temperature, and also sometimes with circulatory arrest. The patient that we confronted before 2 years was a case of cerebral aneurysm, and it was a giant cerebral aneurysm. Some cerebral aneurysms, they are simple with an obvious anatomical neck, so that the surgeon may need, it would be very easy to apply a clip to the aneurysm, not needing any special, let's say, maneuver from us. Sometimes a mild hypotension, or adding, let's say, barbiturate if he wants to do temporary clipping of the feeding arteries until he catches the neck of the aneurysm. But sometimes if the aneurysm is large enough, we may need to induce cardiac arrest. Cardiac standstill using adenosine will give a transient cardiac pause, used to facilitate clipping of large aneurysms with broad neck and to reduce the risk of rupture. The duration of the arrest is only 30 seconds. There will be asystole and can be induced with an average of 30 to 36 milligrams. The recovery is usually spontaneous and needs nothing to do. The other type is deep hypothermial circulatory arrest, Dhca. Not all aneurysm needs this procedure. It is used mostly for giant aneurysms greater than 2.5 centimeters and lack the anatomical neck. They often have perforating vessels originating in or adherent to the wall of the aneurysm. This is an example of a large aneurysm with feeding arteries or perforating branches. And in the diagram, you see that the surgeon has applied temporary clips, and these temporary clips will help in reduction in the size of the aneurysm making it more easy to apply the clip, and also it will prevent bleeding of the aneurysm if rupture happens. Here, this short video will show you the use of adenosine. You see the blood pressure is okay now, the pulse rate is around 45, and as we have administered adenosine, and I believe it was the 30 milligram, you see that slowly the pulse rate will go down along with the blood pressure. This will help the neurosurgeon to apply the clip without putting, let's say, temporary clips on the feeding arteries. You see now the pulse rate is going down. Adenosine, it will affect the atrioventricular node. And you see that you have almost a standstill. You see a complete dissociation. There is a P wave, obvious, but in a few seconds, there will be a complete standstill. Pressure is going down also. That's it. It stopped. And here the surgeon will apply the clip. See, the pressure has gone down so far. The mean arterial pressure is only 40. This will help the neurosurgeon for applying his clip. Because adenosine has a very short half-life of only less than 10 seconds, everything will reverse spontaneously and the heart will start working again. The pressure will go up back to normal. So our patient, he was a 61-year-old hypertensive male admitted to our hospital on April 2018. He was presented with a right-sided weakness and disturbed level of consciousness for 4 hours duration. He had no significant past history other than hypertension, and he was on metoprolol, Kodiavan, and aspirin. He was a smoker and he had no known allergies. On examination, all his systems were normal. The ECG, the echo with ejection fraction of 67, no valve abnormalities, carotid ultrasound and Doppler were normal. All hematological and biological tests were normal. The CT angio revealed a giant aneurysm of 21 by 20 by 16 millimeters in the upper part of the basilar artery with no signs of hemorrhage or ischemia. The team of neurosurgeons asked for deep hypothermal circulatory arrest. Well, what is deep hypothermal circulatory arrest? We have mild hypothermia, which is between 30 and 34, a moderate hypothermia, which is between 25 and 30, and deep hypothermia between 15 and 22 centigrades. And circulatory arrest, there will be no flow during the deep hypothermia. And why do we use deep hypothermia circulatory arrest here? Decompression of the aneurysmal sac when we don't have any circulation and little bit head up position, then the aneurysmal sac will be decompressed. So there will be better visualization of the anatomy, a totally bloodless field, and a greater ease for placement of clip across the large anatomically complicated aneurysm. And of course, the surgeon will have more time to work. As we said, let's say in adenosine arrest, he had only around 30 seconds, but here he will have a lot of time to work on the giant aneurysm. How do we do deep hypothermal circulatory arrest? Well, when the neurosurgeon asked me for that, I asked him, have you done it before? He said no. And I haven't done it before also. So I had to build up a group of different teams and to make them in harmony. It's very difficult to get all these people to work together. Neurosurgeons with cardiac surgeons. Neurosurgeons with neurophysiologists, they work together. Cardiac surgeons with perfusionists work together. But us, we work with all of them. So circulatory arrest can be performed by two methods, either closed chest femoral bypass from the femoral vein to the femoral artery and associated with lower morbidity. And also sometimes we can use open chest with a median sternotomy. Of course, we have to protect the brain during the circulatory arrest, the hypothermia and circulatory arrest. So there, the metabolic oxygen consumption of the brain is divided mainly into active component and basal component. The active component is related to the neuronal activity, and the basal component is related to the integrity of the neurons. The reduction of metabolic oxygen consumption is achieved by two methods. First, we have the barbiturates or the pharmacological method, and the second is the hypothermia. Barbiturates, we reduce the active component of oxygen metabolism of the brain to 0, so that we reduce the overall to 50%. And also it has other effects as free radical scavenging and membrane stabilization. Thiopentol can be given in two modes before cooling and arrest, either a single bolus dose of 30 to 40 milligram per kg over 30 minutes, or we can give a loading dose of 3 to 5 milligram per kg, and then a continuous infusion of 0.1 to 0.5 milligram per kg per minute during the entire period of cardiopulmonary bypass. Barbiturates, they are no longer available in North America. That's why they are using mostly propofol instead of thiopentol, or pentobarbital is also used. I don't know whether in UK do you still use it or not. Hypothermia is a non-pharmacological method of reduction of the cerebral metabolic rate of oxygen. It reduces both active and basal component of the cerebral metabolic rate consumption of oxygen. Hypothermia has been demonstrated to protect the brain during anoxic conditions. So that's why during cardiac arrest, they try to induce hypothermia. It's better than keeping the patient in normal thermia or hyperthermia. Best results have been seen in a temperature between 15 and 18 degrees centigrade. At least two temperature sites should be used, an esopharyngeal transducer or probe, which reflects the temperature of the brain, and an esophageal will reflect the temperature of the heart. So as you see, for hypothermia, the body temperature, as it goes down, the percentage of the oxygen consumption goes down, and the period tolerated for the circulatory arrest will be prolonged. So at a temperature between 20 and 50, let's say around 20, we will have only 15% of the normal metabolic rate of oxygen, and we will have a 32 to 40 minutes period of tolerated arrest. And lower down, you may have more than 1 hour. Hypothermia by itself has a lot of side effects. So it has cardiovascular effect of profound hypothermia. It will decrease as the temperature goes down, the systemic vascular resistance will increase and the cardiac output will decrease. So that's why we may need to use vasodilators, so we can allow high pump flow and facilitate rapid cooling and subsequent rewarming. Progressive bradycardia as temperature approaches 30, then atrial flutter and or fibrillation below 30, ventricles usually fibrillate below 28, and because of continuous fibrillation causes ischemic damage to the heart. That's why we have to either add potassium, give potassium 40 to 80 milliequivalent through a pump, or we use cardioversion. Hematological effect of profound hypothermia. There will be increase in viscosity and reduction in the blood flow, a decrease in erythrocyte deformability, or for example, you have erythrocyte with a diameter of 7 microns passing through capillaries of 5 microns because it changes its shape, but this will be lost in the microcirculation during hypothermia. So we will have a microcirculatory derangement. Hypothermia-induced coagulopathy will occur because reduction of platelet count, probably by splenic sequestration, reversible platelet dysfunction by reduced adhesiveness, slowing down the enzyme-mediated steps of coagulation cascade, decrease in the metabolism of heparin, and dilution effect from the priming solution of the cardiopulmonary bypass for the coagulation factors. As also Dr. Ala mentioned, hyperglycemia occurs because hypothermia prevents proper utilization of metabolism of glucose and may cause hyperglycemia. Cardiopulmonary bypass induces inflammatory mediators, mediate insulin resistance, and hypothermia decreases the release of insulin. Steroids commonly are administered during brain surgery and also will exacerbate hyperglycemia. Hyperglycemia is associated with poor outcome, and it should be treated with insulin, keeping the blood sugar level below 180 milligram per deciliter. So the anesthetic consideration, our patient really had no coexisting diseases, but for example, if we have coexisting cardiac or pulmonary or hematological, neurological disease, may require modification of the procedure. As example, if we have aortic valve insufficiency, you may require to have an open chest method. Patients with poor LV function, coagulopathy, significant carotid artery disease are unsuitable for the procedure. We will need a lot of monitoring during this procedure. So the SpO2 ECG, invasive blood pressures, and tidal carbon dioxide, temperature, at least two sites, esophageal and nasopharyngeal. If available, transesophageal echo for monitoring the heart chambers and the ventricle function, transcranial Doppler, if available, for monitoring of cerebral blood flow velocity and emboli. Both, we didn't have it at that time, really. EEG monitoring is important for monitoring the cortical activity and is necessary as an endpoint for barbiturate-induced burst suppression when they are used for added protection. Somatosensory evoked potentials is a measure of sensory conduction to the cortex and can be recorded even during barbiturate-induced silent EEG. Brainstem auditory evoked potentials reflect the function of the auditory pathway through the brainstem, and so they are useful in the vertebrobasilar aneurysms. Of course, activated clotting time should be monitored because we use heparin in as we go to the extracorporeal circulation. So the induction of anesthesia was uneventful as any other induction, and we used propofol, fentanyl, rocuronium, midazolam, and the maintenance was by remifentanil, isoflurane, and rocuronium. After the neurosurgical team did the craniotomy, they did the dissection of the area, and they did the hemostasis, and after that then, of course, the vascular surgeons also, they prepared the site of cannulation, and then total heparinization was done by administrating heparin in a dose of 400 international unit per kilogram. And after activated clotting time was measured after 5 minutes, it exceeded 470 seconds. So then the vascular team cannulated the femoral artery and vein and were connected to the heart-lung machine. Extracorporeal circulation was initiated, and gradually we reduced the temperature. The reduction and the rewarming should be very slow, less than 0.5 degrees centigrade per minute. So we reduced the temperature down to 17.5 centigrades. The heart started defibrillating at 27 degrees, and it was arrested by the aid of a bolus of potassium chloride 80 milliequivalent. Thiopental was administered by giving a loading dose of 3 to 5 milligram per kg, then an infusion dose of 0.5 milligram per kilogram per minute. The head of the patient was slightly elevated, then the circulation was stopped. So the surgeon started to work on the aneurysm, and he added a clip. He clipped it, and it took a long time. It took 44 minutes. After that, as he ended the clipping, the circulation was restarted for 10 minutes at the same temperature. Then after, rewarming was started by less than 0.5 centigrades per 2 minutes, and the heart started fibrillating at 20 centigrade. We used cardioversion. So we arrested it, then the sinus rhythm was regained by 26 centigrades. Extracorporeal circulation was stopped by 34 centigrades, and when the body temperature was 36, it took around 90 minutes to get back to that temperature. The cannulae were removed, and protamine sulfate was given for reversal of heparin, and the ACT after 5 minutes was reading between 100 and 150 seconds. Hemostasis was done, and the cranium was closed. The EEG and the sensory somatosensory evoke potential showed normal brain function. Acid-base balance was corrected all through the period of the bypass, and after that, the blood plasma platelet were given to restore hemostasis. The patient was transferred to the ICU in a stable condition. So these are pictures only. This is the site of the cannulation, the femoral. This is the cannula inserted. This is the surgical team. And we have, this is the femoral bypass. You see here, we have the normal blood pressure. The temperature is going down to 33.6 here. And here we see that it's 27.9, bradycardia has started, it's 48. And of course, you see here, sorry, we are on bypass here, extracorporeal circulation. Here we have more bradycardia, it's around 38. Pressure is down. And here we have fibrillation. Then we arrested it by using potassium. And here the temperature, as you see, it's 20 degrees centigrade. Still on bypass machine with a pressure of mean around 61. Here we have the temperature is 17.8. No, we are even the circulation, we have arrested the circulation, so there is no pressures, as you see in the invasive blood pressures. And that's the time where the surgeon is working. And these are the two perfusionists working here. Then after that, we started the circulation again after clipping. That's why you see the pressures here, the invasive pressures, and then the temperature going up to 20. This is at 29 sinus rhythm is back, and now on mechanical ventilation. So we have stopped the extracorporeal. Thank you very much.
Dr. Abdul Hamid, many thanks for this interesting case report and interesting technique as well. We have quite a few questions, if you don't mind. The first question is from Dr. Muhammad Saleh Al-Yasawi. The patient was hypertensive. So are there any short or long-term sequelae regarding rapid decrease of blood pressure during the therapeutic arrest? And the other question to follow is that, was there enough time for surgeon to put the clamp?
I really didn't understand the first question.
The question was the long-term effect of reducing blood pressure rapidly in a hypertensive patient. Was there any complications, basically? Can you hear me?
I'm seeing the. I'm just reading the questions here. Your voice is not so obvious. If the neurosurgeon failed to clamping within 10 seconds, we can give a second dose of adenosine. Yes, adenosine can be given 2 times, 3 times if the neurosurgeon needs it. It seems that maximum number of 100.
No, that's not the question, that is.
Sorry?
That's not the question. Dr. Hamid, Dr. Muhammad said the patient was hypertensive.
Was hypertensive, yes.
Yeah. Was there any long-term, short or long-term effect of rapidly reducing blood pressure?
Well, we usually do not do rapid reduce in the blood pressure. In this patient, mean arterial blood pressure within normal when we went to bypass.
Yeah.
And after cooling down everything down to 17.5, we just stopped the circulation. So we have reduced the basal metabolic rate by pharmacological and by hypothermia down to only 10 to 15%. And this will give you a good time for a surgeon to work. Then after that, when we resume the circulation, the pressure goes back to normal. It is the perfusionist who is controlling the blood pressure at that time.
Okay.
He was hypertensive, the patient, but his blood pressure was controlled by drugs. So he didn't have a very high blood pressure.
No end organ dysfunction. The other question, Dr. Abdul Hamid, can you use vasodilators to control blood pressure with some suppression of brain activity, especially if you had invasive blood pressure monitoring and CBP, so you have more time?
I didn't understand it really.
I didn't understand as well. But basically asking if we have an alternative medication to beta blockers, like vasodilators, control blood pressure. I think
for control of blood pressure. Well, you know, if we have a simple aneurysm, for example, we can, there are 2 ways to do it. Either we can, let's say the neurosurgeon put a temporary clip, okay, for the feeding arteries and the aneurysm is shrinked, and he can apply the clip. This will cause, let's say, temporary ischemia of the part of by that blood vessel. Then he removes the temporary clip. This is one way of doing it. The other way of doing it is mild hypotension with mild, or let's say controlled hypotension with mild hypothermia. So you reduce the blood pressure by controlled hypotension, keeping the mean arterial pressure, let's say, at the lower border, let's say, of normal. For example, keeping the mean arterial pressure around 60 in a patient, let's say, or 65 in a patient who is over 60 years of age. If the patient is young, you can even reduce the mean arterial pressure to 55, for example. And with a mild hypothermia, then he can apply the clip. But the subsequence is, let's say, are we going to get global, let's say, ischemia or not after we get to, so this is two types. Either we get local ischemia or we get global ischemia. But we have to be very aware and very precise in controlling the blood pressure.
Yeah. There's a question from Dr. Ali Sahi. Did you need to use inotropes after rewarming?
Yes. I needed inotropes after rewarming. We had to use a small dose of dobutamine for enhancement of the cardiac, let's say, function, the contraction and the rate, and also I don't quite remember, but I think at the end, because of profound vasodilatation, we had to use a little bit of noradrenaline as we are giving the protamine sulfate that causes also hypertension.
Okay, and there's a comment from Dr. Khalil Ahmed from UK. We used 3 grams of thiopentone in UK with deep hypothermic cardiac arrest, but propofol is used more frequently now in North America. Just a comment.
Thank you very much.
And there's another question. What do you do if you can't come off cardiopulmonary bypass?
You cannot come out of the cardiopulmonary bypass. Well, that's a good question. If we know that the patient is unsuitable for going through this, let's say, procedure, we have to exclude the patient. But for example, if we cannot come out of from the cardiopulmonary bypass, it's better to put the patient on ECMO for an extended time and trying to get the patient out of it.
Okay, Dr. Hamid, many thanks for Abdul Hamid. Many thanks for this interesting.
Thank you very much, Dr. Moayed.
And all the best. Our next speaker is Dr. Nawfal Al Mubarak. Dr. Nawfal is a professor of anesthesia and head of the Iraqi Board of Anesthesia in Basra. And he's going to talk about human immunity and anesthesia. So the floor is yours, Dr. Nawfal.
Thank you so much, Dr. Moayed, and good evening, everybody, and appreciated for Dr. محسن ركابي ودكتور رافد وحضرتك ودكتور اياد عباس. Please let me know if my screen is display now or not.
Not yet.
Not yet. Okay. Now?
Yeah, well done.
Okay. I see from the lectures, the lecture like any cascade. It is related with each other. And hopefully I can reach my target to the audience. Actually, since long time, I curiously want to know, is there any relationship between anesthesia and the immune system? Because in our practice, as you know, the number of malignancy nowadays is increasing unbelievable. And because of loss of contact with the patient at the post-operative time, with the decrease, the sophisticated investigation that we can judge this anesthetic drug can enhancing spread of this malignancy or not. But so far about the question about so far the answer about this blurred vision is not funded properly. Immune system, like any sword with double edge, it has many tasks: defense against infection, defense against tumor, clearance of dead cells and tissue repair, but it is still the arrow around. It is still, when it is triggered, can cause a severe harmful and a severe injury and can lead to multi-organ failure once when triggered for any reason. The condition that we experience during anesthesia when give anesthetic drugs can present with the anaphylaxis, with the skin rash, appearance of the skin rash as a result of hypersensitivity. But so far, I want to figure out, is there any relationship with this hypersensitivity, because hypersensitivity is a part of immune response. But is there any relationship between these drugs and spread of tumor or inhibition of immunity and promote the post-operative infection? The question, how does the nervous system affect the immune system? We know that all the anesthetic drugs act on the nervous system, but is there any relationship between nervous system and immune system? Yes, there is a very close relationship. Alteration in the state and function of the nervous system influence the immune response. So the anesthesia, it will inhibit the immune response by indirect way because it is inhibit the nervous system. The nervous system regulate the immune system, the innate immunity. And we will see from the next slide what is the innate immunity and adaptive immune response through the release of neurotransmitter and neuropeptide with the neurohormones. The second question, does the autonomic nervous system control the immune system? The answer, yes. Recently, they found the immune system interact directly within the brain region, and that regulate the autonomic function. If we take back and depend on our background, there is a disbalance in autonomic nervous system during the course of anesthesia. The autonomic nervous system innervate the organ that contain immune systems such as spleen and bone marrow. In summary, the answer for this question, anesthesia interfere with the immune system with direct and indirect way. What are the neuroimmune response to trauma? We have two types of immunity: innate immunity, responsible cells for the innate immunity, monocyte, macrophage, granulocyte, and natural killing cells. Natural killing cells, it is a type of lymphocyte. And this is present since birth, while adaptive immunity that we are taking it from the environment. At the same time, there is a pro-inflammatory and anti-inflammatory chemical substances. What are these pro-inflammatory that release during triggering of immune system? Tumor necrotic factor, interleukin-1, interleukin-6, interleukin-12, interleukin factor gamma, interferon gamma, and anti-inflammatory, interleukin-10, and transforming growth factor beta. So there is a balance between the pro-inflammatory and inflammatory. Mean it is a balance. Once this balance disturbed, there is impaired of immune response. Anesthesia and surgical trauma can cause immune suppression. As said from our colleagues Ala and Abdul Hamid, say that there is an hyperglycemia, and hyperglycemia, it is act as a potent immune suppression because the stress hormone, catecholamine, growth hormone, cortisol, and the other hormones that impede and resist the action of insulin to inhibit, facilitate the entrance of glucose from extracellular to intracellular. This kind of derangement is the main target for how to attenuate this response against surgery and anesthesia. Therefore, predisposing for post-operative infection. Furthermore, stress such as surgery and pain after the surgery that is associated with the immune suppression, which lead to an increased susceptibility to infection and tumor spread. Major surgery, mainly major surgery, and if the major surgery open, most likely has an impact for immune suppression, to do immune suppression more than laparoscopic surgery. So laparoscopic surgery, less immune suppression than open surgery. As we see from this slide, trauma, what kind of trauma, whether surgical, psychological trauma, has an impact for different body organs, like macrophage, increase interleukin 1, and this interleukin 1 increase temperature, white BC, and immunoglobulin G. Enhancing sympathetic nervous system that release the catecholamine can present clinically tachycardia, tachypnea, and vasoconstriction. Physical or psychological trauma can stimulate the limbic and ascending reticular formation that stimulate the hypothalamus, what is called the pituitary adrenal axis. Stimulate the posterior pituitary to release antidiuretic hormone, anterior pituitary prolactin growth hormone, ACTH, with the cortisol in association in the presence of hypovolemia. And the most commonest type of hypovolemia and trauma, what is hemorrhagic and vasovagal. So anesthesia is direct, has played a major role, whether direct or indirect, to inhibit the immune response. Immune response, the problem is not only has a defense mechanism against invasion of the microorganism and prevent spread of a tumor. No, has another important task. It acts as control of homeostatic to regulate of many physiological functions. So the impairment of immune system is not per se to inhibit or to compromise the body against the microorganism and the tumor, no, but most of the physiological, the arrangement happen in organ function. As well as the anesthesia can inhibit mucociliary function of the respiratory, can impair the clearance of the invading to respiratory, and increase the possibility of respiratory infection. A cytokine, profound of cytokine release when immune system trigger as a result of stress to surgery and anesthesia. And so many chemical substances and the neuro and chemical substances released during this condition. These are tumor necrotic factor alpha, interleukin 1, beta, interleukin 6, and interleukin 3. While the anti-inflammatory at the same time, which consider as an against the pro-inflammatory, because both of them, pro-inflammatory and anti-inflammatory, act as a balance between them. Interleukin 10, interleukin 1, receptor agonist, tumor necrotic factor binding protein, tumor necrotic factor, BP, these are also known as a soluble tumor necrotic factor. This is a balance between the inflammatory and anti-inflammatory, what is called CARS, compensatory anti-inflammatory response syndrome, and this is a systemic inflammatory response syndrome. This is actually a balance between the pro-inflammatory and inflammatory. Effect of surgery, as we said, major surgery, open surgery has a deleterious and harmful effect more than minimally invasive laparoscopic surgery. So what kind of drug we can to give if we check these anesthetic drugs? Thiabenton reduce natural killing cells activity, so depress immunity. Propofol reduce as well natural killing cell. Natural killing cell, it is a lymphocyte in nature. Can depress the immunity. Volatile agent inhibit the stimulation of natural killing cell and cytotic in animal mode as well as in human because it interferes with the mucociliary function. Nitrous oxide, the fentanyl and tramadol, the same behavior that depress the immunity. But we see that local anesthetic inhibit tumor cell proliferation. Thank you for regional anesthesia. To give us a hope for given this kind of a procedure confidently and find an alternative method for anesthetize patients of immunocompromise or patient with the malignancy. So at least we can do all our best to do our job perfectly without use the anesthetic drugs unconsciously. That is what I say to say what I want to say. Classical anesthesia. It is not classical anesthesia because we have to be a professional to give a type of anesthesia for each patient. Perioperative blood transfusion. Dr. Ala, he knows that very well in renal transplant, and when I have been in renal transplant branch, that not use a blood transfusion during a course of renal transplant. Blood transfusion considered as an immune suppression. Considered as immune suppression because inhibit the factors that promote immunity. Therefore, we don't need to blood if our patient has a not significant or reasonable blood loss. So we have to be careful to give a blood, and the blood is not milk. Blood is the powerful and dangerous medicine in the medicine. Chronic pain and immunological changes. Chronic pain, yes, can depress the immune system because it increase the pro-inflammatory that trigger the immune system, that suppress the immune system. And sometimes trigger the immune system to cause autoimmune disease and multi-organ failure. So regional anesthesia offering as a considerable advantages by suppressing the cortisol and catecholamine level and reducing muscle breakdown at the post-operative time. So it is attenuate the immune response against the surgery. Such vital organ function and improve the vital organ function, brain, kidney, and heart. And I think Dr. Abdul Hamid knows that the impact of anesthetic drugs, general anesthesia, has a more harmful effect than regional anesthesia. And I have researched that the cardiac enzyme decrease significantly when we use a regional anesthesia than when we use a general anesthesia. So it is better to use a regional anesthesia in such patient who they have immunocompromise or malignancy, but in combination with general anesthesia, sometime the anesthetist try to overcome or hide the successful regional anesthesia by give laryngeal mask, while he don't know that this regional anesthesia working or not working. My recommendation to verify that regional anesthesia we are doing a trial can combine with the regional anesthesia. Surgical trauma, as we said, if we compare the general anesthesia and regional anesthesia significantly reduce the neuroendocrine and cortisol, while general anesthesia increase the neuroendocrine. General anesthesia increase the metabolic and metabolism and the proteolysis and hyperglycemic response, while regional anesthesia significantly depress this kind of response. Regional anesthesia regarding to natural killing, it is stimulated the natural killing, while general anesthesia it is inhibit natural killing. So recommendation to inhibit the proteolysis at the post-operative time, to use regional anesthesia and combined with the sedation and with a remifentanil or propofol in combination after use a successful regional anesthesia. Thank you so much.
Thank you very much, Dr. Naufal. A very interesting and important subject. I will see in the chat if there is any question. One of a question from Dr. Ammar. He asked about how much the target of hemoglobin that below it we should start blood transfusion in immune compromised patient.
Target at the preoperative or postoperative? Preoperative or intraoperative?
Intraoperative for immune compromised patient.
There is no target, because while the surgery is running, there is an hemoconcentration, and we don't find a proper test for hemoglobin. So if we want to give an blood transfusion, it depends on the blood pressure and vital sign, especially in patient with the cardiac disease and patient in neurosurgical operation. Because if we give a fluid, that can increase in intracranial pressure. And as you know, the fluid like crystalloid increase permeation and increase extracellular, increase in interstitial edema. So if we consider these kind of factors, to not give a blood if we don't need it. What is the indication? Indication, the state of patient and the amount of bleeding that can happen during surgery. So it is not necessarily we have to give a blood transfusion or there is a certain limit of hemoglobin.
Okay, thank you very much, Dr. Naufal.
Most welcome.
I think we close your time, and now we're beginning with Dr. Ali Ismail. Dr. Ali Ismail is our colleague from Iraq in UK, and Ali is a consultant anesthetist, working very hard, help a lot of our colleagues from Iraq. Dr. Ali تسمعني؟
اي حبيبي اسمعك.
دكتور علي
شكرا.
اسماعيل. اوكي. welcome.
Good. Salam alaikum.
Brother and friends.
مستحقين نلاحظك.
The microphone and the air now for you.
بس خلينا نشوف شلون هاي نسوي شلون نصعد البرزنتيشن.
Take your time.
انا اسوي لك اياها.
والله كلك ممنون.
Share screen. أنا
just go to share screen.
Share your screen. Share screen. Please all put your mic in mute.
Okay. خلينا نخلي على ميوت.
Click on share screen.
Share your screen.
And then choose the file. Ali, you know this arrow where it says share screen, the green one? Click on share screen and then choose the presentation, click on it and it will be up so you can see it. Ali, are you on laptop or computer? If you just, the lower panel of the, where you can see the photos and I mean for the Zoom, there's called share screen. Click on share screen and then go to your laptop or computer and choose the presentation. Just click on it and we can see it. Or you can email it to me and I can open it for you. Ali, open the presentation first. Open the presentation and then go to share screen. Click on share screen, then go on, click on presentation.
Dr. Rafid, it seems that he is muted. Dr. Rafid, it seems that he is muted.
He can mute himself.
But he can hear. هو صح muted, but he can hear you.
I can hear.
Yes, sure.
Yeah, he's unmuted.
Just let me email you that.
Yes, yes.
Give me a second.
So send me the email with the presentation.
Yeah, I would rather.
وانت لو جايبه يمك رافد وهم انا مغديه.
والمشكلة أنا اليوم on call نكتر. هسه رجعت. هسه.
Did you email it to me?
Yes, just a second. Rafid Aziz at
Hotmail.com. Yeah, that's easy one.
Good.
رافد انت سوي شير سكرين وشوفه وين يروح. تقدر انت تسوي شير سكرين يور سكرين
اوكي.
يشوفك شو تسوي.
Okay, do you want me to do that or have you send it? Have you email it?
I'm going to email it right now. كيفك ما اعرف انت شو.
خلي يسويها قدامك علي، خلي يسويها قدامك. تسوي نفس اللي هو راح يسويه.
ما طول دزها، خليه يفتحها دكتور رافد.
دكتور رافد
دزيتها يا رافد، اذا
افتح السكرين من
تفتحها
يمك.
انت.
اوكي
خلص افتحها من يمك.
افتحها دكتور رافد انت.
خلي توصل ما وصلت.
اوكي
we have time.
رافد ممكن اساعدك؟
البرزنتيشن مالتي مو طويل فبسرعه يعني ما راح اضيع وقتكم.
رافد ممكن اساعدك؟
اي نعم تفضل.
شوف علي، راح اسوي اني شير سكرين. اوكي
علي وين دزيت لي ايميل ما وصلتني؟
هلا رافد عزيز
@hotmail.com.
اي
ما
got it؟
لا.
ليش شوف السكرين مالتي لو لا؟
شوف والله شوف خليل
باوع هذا يطلع عندك باللور بارت اوف ذا زوم. اوكي بس تسوي له شير راح يطلع السكرين مالتك اللي عندك. هسه انا اقدر اطلع لك السكرين مالتي كلها. اوكي
خليل المشكله من اسوي ما يطلع عندي الفايل اللي حافظه بيه.
اي يطلع عندك، روح على الديسكتوب وتلاقي الفايل مالتك.
افتح الفايل وسوي شير. افتح للمحاضره.
اوكي just a second.
انت وين حاطه؟ على الديسكتوب. روح على الديسكتوب.
ده على الفايلز.
اي على الفايلز، روح على الفايلز.
هسه اني ستوبت من يمي.
Okay.
Says you cannot start.
It's okay. I got your presentation.
Good.
Just give me 1 minute.
Okay.
Deal with it. Okay. Can you see it now?
Yes, I can see it.
Yeah, okay. Tell me when you want me to move it.
Perfect. Okay. Okay. Sorry على التأخير. السلام عليكم. What I'm going to talk about, the airway pressure release ventilation. As far as we know, that there are plenty of modes of ventilations in the intensive care, ranging from the BiPAP to the PRVC to pressure control, volume control. However, the airway pressure, next please, airway pressure release ventilation. This is not a new mode of ventilation. It has been found almost 3 decades back. However, the studies about that it wasn't satisfactory to be implemented. It looks like this is the time that we are going to use it, and we have used it, and we found that it's very effective. The reason behind that it causes more recruitment, same as open lung concept, or it's same as the bi-level. Adding to that, it will allow the patient to breathe spontaneously on top of the ventilator, which would encourage the patient self. Next, please. So the aim of the treatment is, first of all, this is not a rescue strategy. This is an early intervention. So it used to be, when it was implemented first, that it's part of the rescue at the end of the management, hopefully, that it will prevent patient deterioration and it slight improve the oxygenation. we have changed this dilemma and we went through another route, which means that we start with that early in order to improve the lung architecture and reduce the alveolar damage and recruit more lung tissue by means that improve oxygenation, and it will allow the carbon dioxide will be on the safe side. However, there will be some elements of the carbon dioxide retention. Next, please. Good. So, what are the potential benefits from this mode of ventilation? It will improve oxygenation. It will reduce the need for sedation. Especially, we have found that during the COVID crisis, that usually the ICU patients are ventilated for a long time when they are on sedation, and although the context sensitive half-life of the propofol and Rami or fentanyl is almost stable, but on the same time it still affects the recovery and the wake up. So we will reduce the need of sedation. It will preserve the muscle strength because the patient will not rely on the ventilator. He will not be ventilatory dependent, and also will not need any muscle relaxant on terms that we are not going to manage the neuromuscular junctions. There will be very good patient ventilatory synchrony, which is very effective to improve the oxygenation. On the same time, it will help the patient to get rid of the carbon dioxide, and also on the end of the day, the mixture of both of those, it will lead that it will improve the recovery and also better hemodynamic tolerance. For this one, it's very important. There are some studies, it says that is the using of airway pressure release ventilation will increase the intrathoracic pressure, which in turn, it will reduce the venous return, and it will, in consequences, it will reduce the blood pressure and the perfusion. However, the increased intrathoracic pressure, it will improve the myocardial contractility, and it will reduce the load on the right side of the heart. This is very effective, and this is very beneficial during the COVID crisis. As far as we know, that during the COVID, majority of the patients in the ICU, they suffer from the either PE or subsequent PEs that will lead to right-sided strain and pulmonary hypertension and right-sided failure. So the implement of APRV will reduce that, and also it will encourage the left side to handle with the afterload. So evidence base for APRV, unfortunately, there are not plenty of studies on that one. There is one very good study. It's that involved more than 60,000 patients in the intensive care that was in North America, and they have found that the recovery is much better, and also the death is much better than the mortality is less than others with the other modes of ventilation. And also there is another study from Hong Kong that involved about 130, that it found that within 28 days, the recovery and the death also is, mortality is less than other mode of long-term ventilation. Next, please. So the setting, I'm just going to go through that one very quickly. There are four things in the APRV when we set the ventilator. There is the pressure, the high pressure and low pressure, and the time. We rely on the pressure to maintain the, as far as we know, the tidal volume, but we rely on that to encourage the patient to ventilate. And we rely on the time to give them. The longer the time, it will give them less or a prolonged PEEP. It means that it will be the same as open lung ventilation. So the pressure to involve the minute volume and the time adjusted to maintain the expiratory flow, or it maintain the, another term we say that it's the PEEP. So mainly it's true that we have to sedate the patient and we start ventilating them, and then gradually we do a gradual sedation hold or tube tolerating, and with that allow them to breathe, and with that they are going to improve the oxygenation and on the same time wash out the carbon dioxide. The most important point with the APRV that we have to accept hypercapnia. So hypercapnia, which is between 6 to 8 kilopascal, it's very acceptable with APRV, and adding to that respiratory acidosis of 7.15 and above is very acceptable. Next, please. So if you look to this chart, this is from the ventilator. As we see that here we need to change the pressure because the tidal volume, I put it in the red circle, that is it's very high, which is not aiming. So we need to manipulate. The pressure it's been mentioned down and the time is mentioned down. So we need to change the slope in order to improve the tidal volume. And on the same time, on the other slide, we will see how to set the PEEP or the expiratory phase. Next, please. This is the slope that we are aiming to improve. That comes in order to manipulate it in the ventilator in order to improve the expiratory phase. That will give us a PEEP, but on the same time, it will encourage the patient to get rid of the carbon dioxide. Next, please. So there are plenty of, there are not plenty of variables in order to play with, not as same as other modes of ventilation like PRVC. You need to change the tidal volume, you need to change the rate and PEEP and IE ratio and the others. Here we rely on the patient to decide which pressure he's comfortable with in order to improve the oxygenation with a proper tidal volume. And on the time, also we rely on how the patient synchrony and also how the patient reacts with our settings in order to improve the PEEP and also to give a good expiratory phase. Next, please. So there are a few troubleshooting. For example, if the PO2 drop, we need to increase the PEEP gradually by 2 centimeters in order to improve of course, the tidal volume, and increase the time. Increase the time, it will reduce the efforts by the patient, so it will get some support from the ventilator, and gradually, as soon as we improve the oxygenation, either we reduce that or try to wean the FiO2 first, and then gradually we reduce the pressures. At the same time, if the pH is very low, less than 7.15, it means that there is bad respiratory acidosis. So we need to wash out the carbon dioxide. Also, we need to change it, and we need to decrease the time gradually in order to give a longer expiratory time, same as we change it from 1 to 1, 1 to 2, and increase it to 1 to 4. The more that we reduce it, the more that it will increase the expiratory phase. Next, please. So in the weaning, we need to reduce the pressure. The more that we reduce the pressure, the more that the patient will rely on himself to produce the satisfactory tidal volume. And also we need to increase the time. Increasing the time, it means that we don't need to recruit the lung by the machine. The patient himself who will provide more of the muscle power. It will help more to improve the expiratory phase, and it will prevent the collapse of the alveoli. And when the high pressure is less than 20, or the high time is more than 8 seconds, it means as same as we are going to switch the patient to pressure CPAP, which is a pre-stage to extubate the patient, then we could just turn off the pressures and we rely just on the time. And that means that it will be just a CPAP to extubate them. Next, please. So as far as I mentioned earlier, that there are plenty of studies and references for this one, but we have found, we implemented that during this crisis and it came out with very good results. So I do encourage that we need to do a study, or we try to implement it, and we will find that there will be very good results and we collect data. Last thing, and always the question that we are always being asked, that as long as the patient is not heavily sedated, not paralyzed, are we able to prone the patient? We do recommend that to prone the patient prior to implement the APRV. It means that we have to try every single effort in order to recruit more lung tissue before we go to other modes of ventilation. Thank you very much.
Thank you very much, Dr. Ali. Very nice, important information in your talk. Thank you very much. Ustad Rafid, المايك إليك.
شكرا جزيلا. Thank you, Ali. I think we are looking at any question. Anyone would like to ask any question to Ali? Okay, there's one question. Can we use, this is from Dr. Ghufran Zahid. Can we use APRV in children and from which age?
Yes, actually, this is a very good question, because the APRV, it was started for neonates. As far as we know that the neonates, they don't have the well-developed neuromuscular junctions. That's why it was started with the neonates. So we could start it from day one.
Okay, thank you. Can we, this is a question from Dr. Mustafa Muhammad Shahab. Can you use it in the ARDS and ALI patients? I'm not sure what that means.
Yeah, acute lung injury patients. Yes, this is the main indication for the APRV is the ARDS. In ARDS, we are going to, there are a couple of things here. We need to recruit lung tissue, and there will be prolonged ventilation. So with APRV, we will implement more lung tissue. The healthy residuals will be implemented. That's number one. Number two, usually patients, they will be prolonged ventilated in ARDS and ALI. So, in order to avoid heavy sedation and prolonged and become ventilatory dependent, I do believe this is one of the modes of choice for such kind of crisis.
Okay. Dr. Muhammad Saleh Elias, أعتقد يمكن yes, you can unmute yourself. You just دكتور محمد.
اوكي، شكرا دكتور رافد. تحياتنا للجميع ودكتور علي. My question to Dr. Ali, did you use this APRV in COVID patient during the crisis, especially for suspicion of pulmonary embolism, that to say right heart strain, or you use for all patients with COVID, or only if there is suspicion of pulmonary embolism and pulmonary hypertension?
شكرا حبيبي دكتور محمد. Every single patient with FiO2 more than 65%, we use it, whether there is a suspicion of PE or not. Because we have found that it does make a huge difference. It reduces the time that the patient spends in the intensive care units.
And what about the COVID crisis? Did you use it in your center?
Sorry, صوتك دكتور محمد.
عفوا, during the COVID crisis, especially in the UK and your hospital, did you use? Yes.
هو دكتور محمد استخدمناه during the crisis.
With good results
it's
on the COVID especially?
It's much better than the PRVC and and volume control or pressure control. It's very superior.
Okay, thank you very much.
Thank you. We have a question from Dr. Talal. Is there any similarity between ARDS and COVID-19?
The similarity يعني بالمانجمنت لو ما فهمت السؤال. يعني similarity بالمانجمنت لو similarity بالباثوفيزيولوجي.
دكتور طلال ممكن تجاوب السؤال؟
اوكي خلينا نقول بالمانجمنت. المانجمنت اوف الكوفيد it's almost different from that for the ARDS. ARDS we rely on the wet lung that we try to dry it, while in the COVID we found that the lung is more dry. On top of that, we rely on the COVID it's the prothrombotic. So there are couple of things. First of all, we are not aiming to dry the patient, because drying the patient more, same as ARDS, and keep them negative will cause more thrombosis. That's number one. Number two, the mode of ventilation is almost similar. However, we try not to use high PEEP, same of the ARDS, because in the COVID, the lung is very stiff, and we found that there are high cases of pneumomediastinum with high PEEP. So we are trying to not to go higher more than 10 to 12. And also on the same way that good thrombolytic agents, it does make a huge difference. That's we in the ARDS, we just rely on unless that the dimer is very high in the ARDS, we thrombolize or we use therapeutic anticoagulant. These are the main changes. And also in the COVID, we are very generous with the hemofiltration.
Okay, thank you. دكتور وليد الأنصاري. دكتور وليد مرحبا بك. Welcome to our meeting here.
السلام عليكم.
عليكم السلام.
السلام عليكم. أول شيء أود أشكر جميع القائمين على هاي الفعالية، بدءا من دكتور رافد عزيز، دكتور محسن، دكتور علاء، دكتور اياد، دكتور مؤيد، وكل المحاضرين. حقيقة فعالية ممتازة وجيدة ومفيدة. This is number one. الشغلة الثانية I would like to thank دكتور علي عزيز على إثارة هذا الموضوع المهم. حقيقة as you know دكتور علي, it is established in the 80s from the previous century by Dr. Nader Hubashi, and we use it in our unit since 2007. We use it especially in those who are in need of high PEEP more than 15. We learned how to use it from American troops. In fact, this is a fact beyond, you know. بس اللي أريد أقول أيضا أنه جوابا على سؤال دكتور محمد الياسري أنه yes, it has been used to treat COVID patients. Especially they use a new modification they named Rescue APRV. They don't let the curve loop, they shorten the time of expiratory phase. Don't let the volume loop goes to 0. Let it to be 75%. تمام دكتور علي، تتبعون نفس الاستراتيجية؟
صح.
اعتقد تطلعتها بالكيرفات اللي طرحتها، بس يمكن لان الوقت قليل
ما حبيت انه اروح على ديتيلز هوايه لانه راح
بس عاشتيدك لانه هذا المود الحقيقه ما كلش مستخدم عندنا، ويعني ان شاء الله هاي المحاضره تخلي الناس تكون more aware about using it، لانه حقيقه كان منقذ للحياه للكثير من المرضى. عاشتيدك وبارك الله بك. دائما you highlight an important subjects. Thank you.
وليد، شكرا لك وعلى جهودك القيمة. شكرا جزيلا. We have a question from Dr. Jamal. شكرا حبيبي وليد. Dr. Jamal, he got two questions. Question one, with cyanotic HD with SpO2 reach 50 to 80%, so they solve the oxygenation by increase hemoglobin. Can we use increase in hemoglobin? So increase O2 content as first treatment before O2 supply.
Increase the hemoglobin to improve the oxygenation?
Yes.
We are aiming of hemoglobin of 80 above and above. So we don't believe that is the blood transfusion will improve the oxygenation, because as far as we know, unless that it's a fresh donation, it's not the oxygen carrying capacity is very low. So it will just blood transfusion will increase the load on the heart, and it will, on top of the already failing heart, it will add more strain. So we have not used it that we blood transfuse in order to improve the oxygenation.
Okay, thank you. A question from Dr. Zaid Jafar Mohammed. What is your idea about non-invasive APRF in some mind-ray ventilators? Are they efficient to use or to use?
APRV? APRV? NIV? Yes. No, it's the NIV. It means that it means that BiPAP. We use it frequently. That is we avoided plenty of intubations with the BiPAP. It means that the non-invasive ones. It's effective. It's effective. But APRV and the non-invasive, there's no APRV in non-invasive. We cannot, because we have to establish a sustainable pressure.
Okay, thank you. Also, I got Dr. Jamal. He raised his hand. Dr. Jamal, maybe it is about your question, maybe earlier, just some clarification, maybe.
Hi, Dr. Ali. Hi, Dr. Ali. Sorry, I think it's nice to use the rule of oxygen content of the blood is important than the use of saturation, SpO2, in managing patient with the COVID as a first line, because using of high oxygen for a long time, it will lead to a toxic effect of oxygen. The cyanotic congenital heart disease patient may reach saturation to 40, and they solve the problem by increasing the hemoglobin. I not infuse patient with COVID with blood to make a heart failure. No, I try to increase hemoglobin, to increase oxygen content, so it helps tissue to survive. This is my idea. Oxygen content better than SpO2.
Okay. Thank you, Dr. Jamal.
دكتور كلامك صحيح. المشكلة اللي what we usually face, there is no silver bullet in the intensive care unit. There are many trials, and any trial can be successful with some and cannot with the others. I don't say that I don't agree with your opinion. I'm sure that it does work, but in general, we don't transfuse from our side. What we have found is very effective, that we try to reverse the hypoxic pulmonary vasoconstriction in order to improve the oxygenation.
Thank you. I got a question also from Dr. Khalil, Khalat Khalil. At which level we have to give blood to patient in a critical care unit in COVID cases?
In COVID cases, in generally, we are aiming of hemoglobin more than 80, unless that there are bit of the other comorbidities or trying not to strain the heart. So the baseline is 80. We accept 80.
Okay, thank you. There's no other questions in the chat side. If anyone have any question, not necessarily to the last speaker, if there's any questions before that.
Rafid,
oh, yes, Khalil. Yes. Okay.
Yeah. In COVID, the problem is not oxygen carrying capacity. It's the failure of lung due to two reasons. A is the cytokinase storm, which fill up the alveoli, and the PE. An increasing hemoglobin may not be on the best interest of the patient because of the severe hypoxic pulmonary vasoconstriction. The viscosity of the blood is important. As the blood gets more viscous, they are called in physiology rheology of the blood. As it gets more viscous, that means hemoglobin of above 13, the flow of the blood through already vasoconstricted pulmonary vessels can be impeded further. So further hemoglobin unneeded is actually not in the best interest of the pulmonary integrity. This is number one. It's all, in COVID, we are not having any problem with oxygen carrying capacity. All the problem primarily happening because of the failure of the oxygen to reach the blood, either because the blood is not there because of the PE or because of the alveoli is filled up with macrophages. So that's my answer for the question.
Fantastic. Thank you. Very good point. Thanks a lot, Dr. Khalil. Any other questions? Okay. I don't know if any comments from Dr. Ala, Dr.
Thank you very much. Thank you very much, Dr. Rafid. Very nice evening, really.
Okay. I don't know if Dr. Abdul Amin is still with us. Okay, I would like to, at the end of this meeting, I would like to thank you all for joining us today for this excellent meeting by, of course, it's excellent because of your presence with us. Tomorrow we have the second day of the conference. Again, we have very good speakers of our colleagues who are going to talk to us tomorrow about other very good subjects. At the same time, it will be 4 o'clock evening Tawqit London, 7 o'clock Baghdad time. I'd like to say something, we are all working hard together, we support each other, and this is the aim of the United Iraqi Medical Association. Please, if you have any comments or any ideas you want us to take on board, just quickly, we have a few minutes before we finish the meeting today. We managed to have a very good discussion with the Cardiff University regarding initiating a Phoenix program for Iraq. We noticed that Phoenix Global did really very well in Africa. We had different logistics between the Iraq and Africa, but unfortunately, we reached the point that we have to do something to help Iraq. Unfortunately, our health system is really deteriorating, and there's no point we can see that this is stopping anywhere. So with your help and with your suggestions and advice, I'm sure we can work together for something that to help the Iraqi doctors, our colleagues in Iraq, and also to help the Iraqi patients. So we're always looking for you to give us any ideas or any suggestions or anything you want us to invest in or to work on. Coming year or this year will be a hard year for all of us, but I hope that things will improve, and I hope that we go back to our conferences and meetings. I would like again to thank all the speakers today for the excellent presentations, and I wish you all the best. Please, there's a feedback form. It is very good for us to know your idea and your feedback, so we can improve our conference in the future. And also it is good also for the speakers to have a feedback. And in the feedback form, you can put your name as you want it to be in the certificate, and your email, so I can send you the certificate with our thanks. Thank you all, and have a good night. Thank you very much indeed.
Thank you.